'Twas the week before Christmas, and all through the house not a person was stirring, not even a... Wait, what are the Bedrock team doing? Whilst the world was singing carols and devouring mince pies, we were busy talking to old friends in the world of dermatology. Now meet Debbie. As an independent market researcher, Debbie reinforced the importance of not just talking to our friends for advice. So we asked her to conduct 10 in-depth interviews with consultant dermatologists right across the UK. Debbie's findings filled 56 slides. We've pored over these, discussed them at length, and cross-referenced them with our own KOL meetings. After a full 8 hours of discussion, we realised it would be a lot quicker and more memorable to show you this short film highlighting our learnings. So, as you know, Novartis have a heritage in immunology, dermatology, and specifically psoriasis, built from the promotion of treatments including Neoral, Lamisil, and Elidel. Of the 10 consultants who Debbie spoke to, 4 mentioned Novartis in dermatology positively and recalled a strong commitment in terms of training and education. 4 were neutral, as they'd had no experience of Novartis, and 2 were negative, as they thought Novartis had been responsible for inducing steroid phobia in their promotion of Elidel, but also due to Elidel being sold to Meda. Some were disappointed that Novartis vanished when Neoral went generic, highlighting how much they valued the relationship previously. This leads us on to our next key topic, relationships. Our research reinforced that relationships are going to be central to a successful launch, whether we're talking about relationships between clinicians, be they dermatologists or rheumatologists, between dermatologists and nurses, nurses and patients, or, of course, between Novartis and all of these audiences. Unsurprisingly, dermatologists want a demonstration of Novartis's long-term commitment to the specialty. They really don't want to invest in a relationship which is going to disappear again. From our research, we have tried to identify those prescribers who are really going to make an impact immediately. We found that it may not be wise to segment clinicians by age. It's not necessarily the younger dermatologists who are more likely to try a new treatment. Some older dermatologists can have more experience, and younger ones can look up to them for guidance and approval. We did find a real difference with regards to attitudes to psoriasis guidelines. We found that, in line with NICE guidance, all doctors would consider 2 systemics prior to a biologic being initiated. However, some consultants told us they are creative within the guidelines in order to treat a patient with a biologic sooner. This tended to be those who employed a collaborative approach to treatment, deciding with their patient and wider team what is best, and then defining the fastest route through the guidelines to achieve it. Another group told us that they rigidly follow the guidelines, exhausting each treatment choice before moving on to the next. And we learnt that others simply do not feel comfortable prescribing biologics at all, often because of deep concerns about safety. Regardless of which segment they fell into, doctors were disappointed that NICE doesn't tell them what to do after biologic failure. BAD guidelines were often described as the most practical, because they state how to use treatments, whereas NICE tells you when to use them. The EADV guidelines were described as better regarding side effect management. Whilst multidisciplinary teams for psoriasis do exist in some trusts, they are not the norm. Over half of those asked have dedicated biologic nurses, and the rest had specialist nurses who also support biologic prescribing. These nurses may have some involvement in prescribing choices, but most importantly, they are the key contact for the patient and carry out the regular monitoring. In some cases, they are also responsible for raising the funding paperwork. When considering psoriatic arthritis, we wanted to know how dermatologists and rheumatologists are involved with patient care. It seems that the GP will initially choose which specialist to refer to, depending on which disease is dominant. The patient will usually remain under that specialist care with little interaction between the specialties. There's little understanding of the data that's relevant to the other specialists' field, although dermatologists expressed a desire to have more knowledge. The most recognised disease impact scale is PASI. Some respondents indicated the increasing importance of PASI 90 as a result of more efficacious treatments. DLQI is also a fundamental score that is required to assess treatment success. So now let's take a look at the launch of secukinumab. What's awareness like out there? Of the 10 consultants interviewed, only 3 spontaneously mentioned secukinumab. Another 3 knew of the IL-17 class, but only recalled secukinumab when prompted, whilst the remainder either had vague awareness of the class or very little knowledge of secukinumab. Encouragingly, clinicians and nurses alike wanted to learn more about the IL-17 class, suggesting a real opportunity to steal a march and educate them around secukinumab. Everyone expressed a desire for good pre-launch education about new products. Consultants told us how they look to the key opinion leaders, as they're likely to be the first to use new drugs, although it's important that we don't leave anyone out. They also told us that education needs to be in a user-friendly, concise format, which is potentially accessible on the go. So what are the other threats to a successful launch? Well, some of the consultants are co-prescribing methotrexate alongside a biologic to enhance the effect and reduce immunogenicity. Over half of the people we spoke to expect that secukinumab would be used after all existing treatment options have failed. Whilst this creates an immediate pool of available patients, it also provides a significant communication challenge to enforce the second-line positioning. Then there's the new CCGs that come into effect in 2013. Consultants are very concerned about having to fight for funding for biologics and think that CCGs could make it even harder. They recognise that they need to increase their skills in negotiating with these new stakeholders. There's also been an overload of information from the biologics companies. Additionally, dermatologists are over-serviced with non-pharma-related education activities and struggle for time to fit them all in. There's a great deal of satisfaction with the currently available biologics. 8 out of the 10 interviewed were using Humira first line and were very happy with it. And what about the data? Consultants acknowledge that head-to-head data is a rarity in their field, but it's something they would really like to see. Most importantly, while they accept short-term efficacy data, they want long-term safety information, and the lack of this is a real barrier to use with some doctors. So now for the good news. Secukinumab is first in class with a novel mode of action. There would be patients available immediately for it, and generally, patients appear to be moving on to biologics more quickly these days, as dermatologists feel a lot more comfortable prescribing them, but still feel that there's room for improvement. And all of the consultants interviewed said they want to learn more about IL-17, want to build relationships with a company who is committed to improving psoriasis treatment, and most importantly, would use secukinumab, some even indicating that they would use it straight away. So thank you for watching. Let's move on to what we believe needs to be done over the next 24 months, based on the insights we've just seen, to gear up for a highly successful launch.